Hi, everyone, and welcome to today's Journal Club, the January Journal Club. I'm Pedro Ramirez, Editor-in-Chief of the International Journal of Gynecological Cancer. I want to thank also, of course, obviously, ESGO and the IGCS for their support of our Journal Club. Before we begin, I want to just mention a few housekeeping notes relevant to the Zoom platform for today's Journal Club. We're recording today's discussion, and the recording will be made publicly available. The participants with cameras turned on may appear in the video recording, and we ask that everyone please keep your microphones muted so everyone can hear the presentations. If you're having any difficulties or questions, please send a message in the chat, and our technical support will assist. We always, of course, obviously encourage everyone to submit questions throughout the Journal Club. And then certainly we hope that you will send in those questions for a lively chat and discussion. So this month's lead article is titled Transfusion Use and Effect on Progression-Free Overall Survival and Quality of Life in Upfront Treatment of Advanced Epithelial Ovarian Cancer, an evaluation of the EORTC cohort. And the author and lead author of that article is Lauren Prescott. So we're really happy to have Lauren join us for this Journal Club. Lauren is in the Department of Obstetrics and Gynecology at Vanderbilt University Medical Center in Nashville, Tennessee. So welcome to the Journal Club. And Lauren, once again, thank you so much for joining us and spending time with us to discuss this really very important topic. So we look forward to your presentation.
Great, thank you. Thank you all for having me. So let's see, let me just flip over to the slides. Okay, so as Dr. Muir said, I'm going to go through kind of a brief summary of our manuscript entitled Transfusion Use and Effect on PFS, Overall Survival and Quality of Life in Patients with Upfront Treatment of Advanced Epithelial Ovarian Cancer, Evaluation and Treatment of the EORTC 55971 cohort. So a little bit of background information. So the prevalence of perioperative transfusion after cytoreductive surgery for ovarian cancer is very high, with prior studies citing rates anywhere from 42 to 77%. Transfusions are often used in the perioperative setting to improve oxygen delivery to tissues, ameliorate symptoms of anemia. Unfortunately, blood transfusions are not without complications, and several studies have suggested that blood transfusions are immunosuppressive and associated with increased perioperative morbidity, mortality, and cancer recurrence. To date, there's only been a few studies that have evaluated the impact of transfusion on PFS overall survival in advanced ovarian cancer. And to our knowledge, there's been no studies that have evaluated the impact of blood transfusion of quality of life. In the previously mentioned studies, there's been sort of mixed data about the impact of transfusion on PFS and overall survival. Therefore, we sought to investigate the impact of perioperative transfusion on PFS, overall survival, and quality of life in patients with advanced ovarian cancer. To do this, we performed an ancillary analysis of the EORTC 55977 randomized study, in which patients with advanced ovarian cancer were randomized to primary debulking surgery versus neoadjuvant chemotherapy. Between September of 1998 and December of 2006, there were 670 patients with stage 3C or 4 ovarian cancer that were randomized to primary debulking surgery versus neoadjuvant chemotherapy on trial. Of those, 38 were ineligible or did not start the allocated treatment, and 20 additional patients were excluded from our ancillary analysis because of missing intraoperative transfusion data. The demographics and operative characteristics are not listed on these slides. They're available in the manuscript in tables 1 and 2. Sort of big take-home points were the transfusion cohort was more likely to have better PFS performance status, serous histology, undergo primary debulking surgery, receive more aggressive surgery, and have higher rates of no residual disease. Sorry. Of the 612 patients, including our analysis, 53% received an intraoperative blood transfusion and 13% received a postoperative transfusion. All patients who received a postoperative transfusion also received an intraoperative transfusion. Transfusion was more common in the primary debulking cohort compared to the neoadjuvant chemotherapy cohort. And transfusion rates among participating countries that entered more than 5 patients on trial were highly variable, with rates ranging from 17 to 91%. As you can see here, there was no difference in overall survival or PFS between the two cohorts. There was also no difference in quality of life symptom scores, which were assessed at baseline after cycles 3, 6 of chemotherapy, and then 6 and 12 months follow-up. With regards to postoperative complications, we looked at perioperative complications within 28 days of surgery, as depicted in Table 3. Grade 3 and 4 complications were more common in the transfusion cohort than in the no transfusion cohort, specifically hemorrhage, dysarrhythmias, hypotension, and infection. So in conclusion, blood transfusions do not appear to be associated with changes in progression-free and overall survival. However, they are associated with increased perioperative morbidity without clear evidence of improvements in quality of life.
All right. Well, thank you so much, Lauren, for the presentation and this very, very nice summary. So we're going to start with some points of discussion and some general points that I like to bring up, and love to hear your response to these. You mentioned that 53% of patients undergoing surgery undergo transfusions. And this to me seems very high. And one would then question, do all these patients really need a blood transfusion? And one of the things that we always remark with regards to the implementation of enhanced recovery programs is that the criteria that are used to give blood transfusions are quite stringent, and typically under the enhanced recovery guidelines, one should not give a transfusion unless the hemoglobin is less than 7 or the patient is symptomatic. So I just kind of wanted to hear your thoughts with regards to this high percentage of transfusions in patients undergoing ovarian cancer surgery.
Yeah, so actually there's a recent article that was just published that was an update of the NSQIP quality improvement study that I had done as a fellow a few years ago. And unfortunately, we are still seeing pretty high rates of transfusion in the perioperative setting for advanced ovarian cancer. So it doesn't look like the needle has moved a ton in the last few years, which was a little bit surprising to me. Certainly 53% is pretty high, and some would sort of argue, like you said, that in the setting of enhanced recovery, more restrictive protocols, that perhaps those numbers would be lower in a more contemporary setting, but that actually does not appear to be true. The transfusion prevalence still is high, and these are high risk patients. They're anemic for those who've had chronic disease, chronic illness. They're often malnourished with vitamin deficiencies, which also contribute to their anemia. And then for those who are getting chemotherapy, they may have some issues related to anemia from their antiplastic chemotherapy. But it's hard sometimes to parse out the indication for transfusion. I mean, that's missing from this data. So are these patients having issues with acute blood loss in the operating room getting transfusion? Are there opportunities for which some of these patients could have not received blood? And that sometimes is a little bit harder to parse out. But yeah, the prevalence of transfusion being so high is still, I think, a little astonishing.
Yeah, and I think another point is that particularly when looking at ovarian cancer surgery, obviously we know that there's a decrease in morbidity in the interval cytoreductive surgery as opposed to the primary cytoreductive surgery, and wondering, how does the complexity of the surgery and how aggressive you are in the surgery play into your criteria for giving a blood transfusion? And I don't know if you had some thoughts on that.
Yeah, and I think, like I had mentioned earlier, the patients who had primary debulking surgery definitely had higher rates of transfusion, but that was 50 versus 46%. So we're still looking at pretty high rates of transfusion in the interval neoadjuvant group. Again, that may be more from impact related to chemotherapy on bone marrow, but the prevalence of transfusion in that cohort is still pretty high. But yeah, certainly sort of more aggressive surgery, higher risk of blood loss, higher risk of potential for transfusion. So, I think this may speak to there could be sort of an opportunity to optimize patients before you take them to surgery. And can you sort of boost them up before you put them in a situation in which you are going to anticipate a large EBL, increased morbidity and need for transfusion.
Yeah, absolutely. And I'll get to that point a little bit later, but now we'll pass it on to some of the questions from our fellows in the journal, and welcome to all of our fellows. I believe this is your first journal club. So the first question will come from Giulio Bonaldo from Italy. Giulio.
Yeah, thank you, Dr. Prescott, for your presentation. My question is, what did studies investigating blood transfusion and ovarian cancer show in the previous published literature? And what were the difference of those studies and your study? Thank you.
Yeah, so, prior to this manuscript being published, there were 9 prior manuscripts that had looked at the impact of transfusion in advanced ovarian cancer. 8 of those were single institution retrospective studies. One of them was a meta-analysis that had looked at all but one of those previous studies. And those previous studies, ultimately showed some discordant results. So 4 of those studies showed that blood transfusions did have an impact on PFS and overall survival. 3 of them showed that blood transfusion did not seem to have an impact on PFS and overall survival. And then when the meta-analysis sort of put that all together and their sort of ultimate conclusions was that blood transfusion, when you take into consideration some propensity matching, probably was not an independent risk factor for survival. But I think there's sort of several reasons that may kind of explain some of these mixed results. First is that each of those studies uses different definitions of perioperative blood transfusions. So we used, within 28 days of surgery. Some people use within 72 hours of surgery. Some people use a month. Some were longer than that. And second, blood management studies have shown that not all blood is created equally or stored equally, and that there's variations in how you process blood, such as the age of the blood, leukocyte reduction, blood type, and those actually may be some confounding factors in impacting some of the negative effects of blood transfusion that we have seen. But a lot of blood studies, storage, processing information is not available when you're doing retrospective data. So it's a little bit harder to parse that out.
Yeah, and Lauren, we have thank you, Julio. Lauren, we have a question from the audience, and I think you touched on it a little bit with regards to the days before or after the surgery that is considered a perioperative transfusion. And do you think that everybody's kind of using the same terminology?
No, I don't. So, in the NESQIP data, they use 72 hours. But in a lot of sort of single institution retrospective studies, people use 28 days. When we look at complication outcomes, I think most studies tend to use 28 days. Some go up to 60. So, I think that does create some variability and sort of comparing apples to oranges when you're looking at different papers regarding sort of the prevalence of transfusion and the outcomes. I don't think there's a right or wrong answer. I think most people sort of, probably perceive that the impact of blood transfusion is a little bit shorter acting. So perhaps looking at the full 30 days is more than you truly need to study the impact of transfusion, but that's traditionally been kind of the amount of time that we've used for perioperative outcomes, which is why we included the full 28 days after surgery.
Great. And Lauren, another interesting question from the audience, and interested in hearing your thoughts. Is there any relation with regards to the volume of blood transfusions and morbidity? So in other words, if you say, well, I'll just give one, this is not so bad, but obviously giving 4 or 5 is that different? And one would presume that it is, because if you're giving 5 units of blood, then you probably got into some serious bleeding during surgery. But any thoughts on the actual volume at which the morbidity starts really increasing?
Yeah, so that's been a little bit harder to parse out. But we have seen from some of our other work that even just 1 unit of blood is associated with increased risk of perioperative complications. Some of the patients who, in the work we've done before, who had emergent surgery, who had pelvic exenerations, who had significant sort of preoperative blood loss and needed multiple units before going to the OR, have been excluded from some of these studies. So sometimes I think it's harder to answer that question. But we do know that even just 1 unit of blood is associated with increased perioperative risk, but certainly, I think you could surmise that more, maybe even more harmful, but I would say I don't think we have that data.
Yeah, and Lauren, I mean, I'm sorry for the rapid firing of questions, but there's so many questions
Oh,
that
you're
are coming
good.
in. So really, and you're doing great, by the way. So, but really interesting questions. And the next question is from Giuseppe Caruso, and he's asking about the importance of preoperative anemia and iron stores, and how do we optimize patients? It's not just about, okay, well, you're anemic, let me give you blood and everything will be much better. Now there's programs in prehabilitation for enhanced recovery as well, in order to optimize, including the hemoglobin preoperatively. Is it something that it's being done proactively? Should the hemoglobin level of 12 help reduce this transfusion rate?
Yeah, so great questions. Yeah, I think, as enhanced recovery becomes the standard of care, I think the next horizon is really perioperative optimization, and what can we do to make these patients healthier and better to take before we take them to the OR. Particularly the neoadjuvant chemotherapy patient cohort, you have this 3 months time to prepare them for their surgery. I think this is a really great time for us to do a much better job at, like you said, prehab, evaluation of nutritional deficiencies, which includes B12, anemia, iron, checking their vitamin C. We have started to do a much better job at our institution of looking at the prevalence of vitamin deficiencies. And it's pretty astounding how many patients are deficient in C and D. And so I think there's a lot of things that we can do to optimize patients. Vitamin C has a pretty significant role in sort of your coagulation pathways, and so can actually probably impact potentially the need for blood transfusions as well. So I think we can do a better job of evaluating these patients before surgery, potentially for those who are truly iron deficient, giving them IV iron to help boost their stores so that when you encounter high blood loss, perhaps you are still in a place where you may not necessarily need to give them a blood transfusion. So I do think that that's sort of the next forefront of how we potentially decrease some of these high transfusion rates in this patient population.
Great. So next we'll go to one of our other fellows, Jen Davis Oliveira, as she has a question for you regarding other types of tumors, I believe.
Hi, thank you so much for the presentation. Is blood transfusion good for other tumor types? And does your data show similar results for other tumors like colorectal or lung cancer? And if it is the case, why do you think this may be or not?
So I have yet to find any data that blood transfusions are good. So I think where the controversy exists is truly, are they really harmful? But I would say there is no data that they are beneficial. So in other disease sites, like you mentioned, lung, colorectal, there has been numerous retrospective studies that have been published that suggest that blood transfusions are harmful, with increased morbidity, mortality, cancer recurrence, impact on survival. So I think where some of the differences in the results of our study compared to other tumor types are kind of similar to why the results of this study may have been different from some of the advanced ovarian cancer patients, that there's a lot of sort of unanswered questions regarding blood storage, measurement that is more challenging to manage. But I think the big take-home point from your question is there's no data that it's beneficial. the degree of harm is in question, but I would say definitely no data that it's beneficial.
Exactly. So actually, Jen, you have another really good question. Why don't you go ahead and follow it up as well?
The one about tranexamic acid.
Yes.
Did you get that data as to whether tranexamic acid was given and whether this would potentially reduce the rate of blood transfusion?
Yeah, so that data was not available for this manuscript, but I think that's a really good point. And there was a quality improvement project that was done out of the Mayo Clinic that looked at sort of a bundled approach to try to decrease blood transfusions by including tranexamic acid as part of their perioperative management. And so unclear about kind of which of the components of the bundle may have been the most beneficial, whether it was pre-op iron, intraoperative tranexamic acid, trying to minimize your blood loss, but it kind of seemed like the bundled approach was beneficial to decreasing the use of blood transfusions. And we've definitely seen that in other disease sites as well.
Great. And Lauren, getting back to some of the questions in the chat room, the hypothesis that blood transfusions are bad for you or for the cancer patients, particularly as it pertains to oncologic outcomes. So there are some discussions as to the fact that blood transfusions may be associated with worse progression-free survival and worse overall survival. Any thoughts on that hypothesis?
Yeah, so I think some of that is a little bit related to this concept that transfusions may be sort of immune modulating. And so I think part of the understanding of why blood transfusions may be associated with increased risk of cancer recurrence and impact on survival is sort of this immune microenvironment. And so for those of you who aren't quite as familiar with this topic, the proposed mechanism of transfusion associated adverse events has been really attributed to alterations in the immune system, termed transfusion related immunomodulation. And this concept originally sort of came out of patients who were undergoing renal transplants who had blood transfusions, that those patients seemed to have improved allograft survival. So sort of next step was to kind of look at some animal models to investigate this role. And it seems like when you give blood in animal models, you can suppress natural killer cell function, induce suppressor T cells, decrease the function of macrophages, and alter antigen presentation. So it's sort of been postulated that perhaps some of these cellular changes may be the underlying mechanism for the adverse clinical effects that we're seeing, such as increased infection, VTE, cancer recurrence, or mortality. But, I think there's still a lot to be sort of parsed out from this, but I think that's kind of under some of the underlying mechanisms of why we think this might be happening.
Great. Lauren, next we're going to go to Georgia, our fellow from Georgia, Javansa Koshiashvili. I'm still practicing on pronouncing your last name, Javansa. Please go ahead.
Hello, everyone. Thank you, Dr. Prescott. So results of your EORTC QLQ C30 symptom score showed a slight decrease in global health status and physical functioning with more fatigue. What could be the reason?
Yeah, so even though the mean numbers were a little bit less, they were not statistically significant between the two cohorts. So I would say it's hard to sort of discern any meaningful clinical significance. One, there's pretty high variability in a wide standard deviation in those patients. So I think that may be part of the reason you're not seeing a big difference in improvements with transfusion, but kind of based on the data, I would say they're not statistically significant.
Excellent. So I think the next question is from Teresa in Austria. And I think that you touched a little bit already on some of the immune modulation, but I think Teresa has something to beyond that point as well. Teresa, you go ahead.
Hello, thank you, Dr. Prescott. Yeah, actually, you quite partially answered what would have been my question and was incredibly interesting. Talking about immunomodulation or transfusion-related immunomodulation, do you think that this will play a role also considering that we're going to use more and more immunomodulation therapy in gynecology?
Yeah, so I think, ovarian cancer is pretty complicated, and we've seen really great outcomes in some other disease sites with some of the immune-mediated drugs that I think a lot of us have perhaps been a little disappointed that we haven't seen quite profound improvements in survival for ovarian cancer with some of the immune drugs. And I think that probably speaks to the complexity of the immune microenvironment in ovarian cancer. And so, my guess is ovarian cancer just may be a little bit more complex than some of the other disease sites. And there may be a lot more sort of competing factors in addition to just the immune system that may potentially confound some of the results of the transfusion-associated adverse outcomes, but as well as the reason perhaps we're not seeing as quite robust response to immunotherapy in this disease site.
Excellent. So Lauren, the next question comes to us from Andrea Rosati, who is at Gemelli in Rome. Andrea, please go ahead.
Hi, thank you. Thank you, Dr. Prescott. My answer is, your study showed that there were high variability of transfusion practice among countries in the ORTC trial. What are the implications of this finding?
So we know from a lot of other working quality that procedures or interventions that have high variability often mean that either one, there's a lack of good evidence, or two, there's a lack of implementation of evidence-based guidelines. And so I think that sort of holds up in this data as well. Seeing high variability in transfusion practices may be related to the fact that there aren't great established guidelines about management of blood transfusion in cancer patients. When we sort of started this work, there was definitely a lot of sort of discussion and heated discussions about, what is safe and what's effective in cancer patients. And perhaps I think that's still problematic, that there's a lot of individual biases about how one should transfuse and manage patients. And so the evidence isn't clear. And then implementation of the evidence that's available is not great either. So I think that's sort of, this is a really fabulous opportunity for improvement, for quality, for decreasing cost and complications for our patients. And I think the data sort of suggests that this high variability suggests that we haven't sort of achieved that mark yet.
Yeah, it's interesting. And I think also a lot of that applies from even institution to institution and even within practitioner to practitioner as well, as it pertains to the criteria. And we'll talk a little bit more about that in a second. One of the questions from the chat room was about doing propensity matching to evaluate this particular question. Do you have any comments or any thoughts on that, Lauren?
Yeah, I think that's been done in some of the retrospective studies, and then the meta-analysis that was previously published on transfusion in advanced ovarian cancer. The meta-analysis that used propensity matching did not show a difference in PFS or overall survival. I think this is a tough endpoint to identify and achieve. We see the same problem in a lot of our clinical trials as well with different drugs. So I don't know that would have sort of helped alter the outcomes that we saw in this particular study, but that has been utilized before.
Excellent. So I think that our next question is from Anissa Mburu, and she's in Kenya. And she'll have the next question for you with regards to practice.
Thank you so much, Dr. Prescott. This has been quite interesting. Now, what should the authors suggest as an optimum cutoff for blood transfusion products, especially in advanced cervical ovarian cancer? Meaning, beyond what can one be cautious? And if so, do you follow any particular guidelines for transfusion practice? Thank you.
So I think, current best practice guidelines suggest that we shouldn't be using a number. We should really be relying on patient symptoms and clinical scenario to help guide transfusion. So, I think a big important point that this brings up is that not all types of anemia are equal. So there's a big difference between a sudden acute blood loss anemia in the operating room and a chronic anemia in a patient who is undergoing chemotherapy and who's been living at a hemoglobin of 7. So I think you do have to take into consideration some of the patient factors in your decision of when to give blood. I'm more likely to give blood if I'm hemorrhaging in the operating room and a patient started at a hemoglobin of 14 than I am if my patient's getting chemotherapy and their pre-op hemoglobin is 7 exactly. So I would say I tend to be much more restrictive in my practice, particularly in that outpatient chronic anemia setting, and utilize symptoms of anemia and really try not to transfuse patients if their hemoglobin is above 7. If they're symptomatic or it's a sudden change for them, then that's different. The operating room is a little bit trickier just because of the volatility of the scenario. If you can lose a lot of blood very fast. And so I think you do need to be sort of on top of your ability to get blood. And part of it depends on where you practice. If you're in a trauma setting that can get that massive transfusion protocol pretty rapidly, I think your ability to kind of wait a little bit longer is probably fine. If you're in a place that doesn't actually have great access to blood and you're operating and somebody's bleeding, then you may need to sort of stay on top of it a little bit more. So I do think that the clinical scenario impacts my decision of when and how I give blood, but I do tend to be much more restrictive.
Fantastic. And then we'll switch over to a question from the audience. This question is from Giuseppe Cucinella. Giuseppe, how are you? Do you want to go ahead and ask the question?
Yeah, hi, thank you so much. Thank you for
and I should say, one of the upcoming fellows of the International Journal.
Yeah, thank you for the presentation. My question was about if you did a sub-analysis including only the patient that received intraoperative transfusion instead of including all the patients. So if you consider only the patient with intraoperative transfusion, there are any difference between the other 82 patients who received also perioperative transfusion? And the second question is, if you consider only these patients, so the patients who receive intraoperative transfusion, and you compare the outcome with the no transfusion group, what about the perioperative morbidity? Is it still higher in the transfusion group? Thank you.
Okay, so let me make sure I understand the question. So if I look at only the patients who receive an intraoperative transfusion and exclude those who receive the postoperative transfusion, the outcomes that we see are similar. So in this manuscript, there was 14 patients who had a postoperative transfusion. All of those patients also received an intraoperative transfusion. So harder to eliminate or to evaluate just the role of intra-op transfusion in this particular study, because we do have 14 patients who did get a post-op transfusion, but if you do exclude them, your results are similar.
Thank you.
Excellent. And Lauren, I wanted to ask you, what about patients where they're going to get chemotherapy soon after the surgery versus those that they're not going to get any more treatment? Should there be differences with regards to your criteria for selecting to give a blood transfusion, or the same rules apply?
I think that's probably been some rationale for why some people feel more strongly that they should transfuse these patients, is because they're going to go on to get chemotherapy. But we don't actually have any data that's beneficial, that impacts the time to receipt of chemotherapy. And I think, what we've sort of seen in practice is that even those patients who are pretty anemic when they leave the hospital, by their 3-week post-op visit, when they're needing to get chemotherapy, their body is starting to rebuild some of those stores. So that perhaps it's not necessary to give them blood solely for the purposes of building them up in anticipation of chemotherapy.
Great. So let's see if there are any additional questions. We have another question from the audience. To avoid blood transfusion, would you consider anemia per se to be one of the indications to treat with neoadjuvant chemotherapy rather than an upfront surgery, and use that 2 to 3 month period to optimize the patient's anemia. So in addition to all of the other factors that we use to determine surgery now versus surgery later, should anemia be one of those elements that determines to do the surgery later?
Yeah, I think when we think about the decision to do upfront versus neoadjuvant chemotherapy, we take into consideration both tumor factors and patient factors. So, one of those patient factors, I think, is anemia. I would say anemia alone would not be enough for me to not offer a primary debulking surgery, but anemia in combination with a poor performance status, profound other vitamin deficiencies, other factors may sort of push me to give them neoadjuvant chemotherapy. Some other studies have suggested that the transfusion rates in patients who undergo neoadjuvant chemotherapy is actually higher than those who have primary debulking surgery. That was not true in our study, but that we have seen that in other retrospective studies that have been done in the US. So, again, I would say anemia alone is not enough, but it may be sort of one of the factors that play into my decision.
Yeah. And Lauren, we've been talking about primary surgery and interval surgery. Is there any data as it pertains to this topic in secondary cytoreductive surgery?
Sorry, say that again.
Is there any data as it pertains to transfusion and outcomes in like secondary cytoreductive surgeries?
Okay. Not that I have specifically seen. I have not sort of seen any retrospective studies that have looked at sort of specifically the prevalence of transfusion and the impact with secondary tumor reductive surgeries. So I would say I don't know the answer to that one.
Okay. And there's another question from the audience with regards to the use of intravenous iron infusion. Is that something that should be recommended in this particular setting?
Yeah, so the benefit of IV iron is sort of a rapid improvement in your hemoglobin. So it's often used in patients, one, who don't tolerate oral, two, in patients for whom you have a shorter time period in which you want to sort of boost them. So it's safe to use pre-op, it's safe to use post-op. We have used it as soon as like post-op day 1 in some of our patients to try to avoid transfusion. And sort of same on the flip side, you can use it kind of any time leading up to surgery. It's not harmful that we are aware of. Okay,
great. And Lauren, one additional question, because we're coming towards the end of the Journal Club. Where does the research lie now with regards to this concept? Are there any studies that either you are doing or are aware of others who are doing to explore this further?
We are really interested in sort of perioperative optimization right now. And so, looking at the prevalence of anemia, but what kind of anemias, what kind of vitamin deficiencies, I think with the question of IV iron, if you have a chronically, you have anemia because of chronic disease or neoplastic chemotherapy, then IV iron may not be quite as beneficial. So I think parsing that out is an area of interest, trying to sort of figure out how to best optimize these patients before surgery is kind of where our team is going with kind of the next horizon for trying to decrease transfusions and optimize patients for surgery.
Great. And Lauren, there's a couple more questions that just came in from the audience before we let you go. The question on auto donation or the use of cell savers in order to prevent blood transfusions. Any thoughts on that?
Yeah, I think, particularly, ovarian cancer patients that are anemic going into surgery, we don't want to make them more deficient. And so, I strongly encourage patients against auto donation because you're going to make yourself more deficient. going into surgery. And oftentimes it's not that you have a long time to sort of prepare and rebuild. You know, you're doing surgery within a couple weeks of chemotherapy, or you're doing surgery right away once you have a diagnosis. And so I would say just sort of deplete somebody for the purposes of giving the blood back to them and avoiding transfusion is probably not wise in this patient population.
Yeah, and then I think that out of courtesy to the doctor in the audience who's asking, Matteo Magnini, not directly related to this topic, but he's asking, is there any role for pre-op albumin replacement in patients with low levels of albumin?
So, you know, I think that one, you know, we know albumin is not a great marker of malnutrition. It's not quite as sensitive and specific. We don't really have great markers for preoperative malnutrition. We also don't know that artificially giving somebody albumin is going to sort of help them kind of increase their hemoglobin levels, or, you know, not third space their fluid. So I would say we don't have great data whether that would be beneficial. Albumin also seems to be sort of very short acting, and so it's used in the OR kind of for quick retention of fluid, but perhaps pre-op may not sort of last until they get to the OR. So I would say insufficient data, but just given the mechanism of how it works, may not be a great option.
Great. And then one last question. They're asking any suggestions you have for us in the audience to avoid perioperative transfusions. What should be like the take-home messages to not give transfusions?
Yeah, so I think, you know, one, you know your data. You know, where do you stand? Where does your institution stand? How do you compare to sort of national, international norms? You know, do you actually have a problem where you are? Are there things that you guys could do to improve? Or are you actually doing really well with low perioperative transfusion rates? So I think number one is kind of know where you stand. Number two, I think, you know, again, sort of a big focus on perioperative optimization. How can we get patients ready for surgery, and what can we do to sort of decrease the risk of not just transfusion, but complications in general, I think is really kind of the next horizon and forefront for ovarian cancer surgery.
Well, Lauren, thank you so much. We really appreciate it. First of all, I think that we can all give you a big round of applause because you did incredibly well with so many questions in a short period of time. Thank you so much. I should also say that Lauren was a former fellow at MD Anderson, so obviously continuing to make us all very proud. So thank you for your time, Lauren, and thank you for submitting this work to our journal.
Thank you so much for having me. Really appreciate it.
All right, great. So I just actually want to close by saying that the recording of today's session will be available in the journal, as well as the IGCS and ESGO website. And I want to invite everybody to the next journal club in February, where we're going to be speaking to the group from Gemelli Hospital in Rome on the article titled "Role of Minimally Invasive Secondary Saddle Reduction in Patients with Recurrent Ovarian Cancer." So I hope to see you there as well. And Lauren, thank you once again.
Thank you, Dr. Ramirez. Thank you all.
Bye. Thank you very much.